So what do you know about the musculoskeletal system? There's muscles, there's ligaments, tendons, bones. Yeah, the muscles and the bones, right? All right. Yeah, I mean that's it in a nutshell. Okay, we're gonna kind of expand a little bit from there, hopefully. But yeah, it's our system that we have for movement. Okay, we got to have the musculoskeletal system working for us to be able to move, for you to be able to get up and walk out of the classroom, for you to be able to sit there and take notes. All that, you know, is the musculoskeletal system in action. So let's go through the objectives real quick. And just like last time, these objectives are pretty important. This is kind of what we're basing our content on. This is what we look at to determine what we're going to test you on. This is what we look at to determine what we're going to teach you. So yeah, I mean this is a good little study guide here. Okay. Number one, you should be able to explain the anatomy and physiology of the muscular system. Okay. A lot of this stuff you've probably already touched. We're going to kind of go into it, review a little bit, and we'll go a little more in depth. You should also be able to define terms associated with the musculoskeletal system, describe diagnostic tests that are used in musculoskeletal system traumas and also alterations. You should be able to describe selected musculoskeletal system traumas and their alterations, and also interpret clinical manifestations that are used to determine and diagnose musculoskeletal system traumas and alterations, and also the pharmacological agents that we use to treat. Also the nutritional considerations used in the treatment. Also describe the nursing process, and that's a big one right there. To be able to take what we've taught you and implement that in the nursing or clinical setting, but also on your tests. Okay. The process for implementing a care plan. Okay. So how do you plan out your care for a patient with a musculoskeletal system issue? Next, we've got CAS care. CAS care and the complications that go with that. Identify techniques for various crutch walking methods and also the various traction methods. Identify expected outcomes of treatment modalities of musculoskeletal system trauma and alterations, and then describe the techniques for managing chronic pain. Also, use critical thinking to prioritize management of care. Alright, so these are your objectives. This is kind of what you need to base not only your study time, but you know, the practice questions. You need to look for things that are going to address these issues. Alright, so kind of a quick review. Some of the key terms. This is not all of them, but a lot of the key terms that we'll use throughout the module here. Muscle contraction is a shortening or tensing of a muscle. Okay, so what you've got to use to be able to move the skeletal system, be able to move the perform any function related to mobility. Contraction is the ability of a muscle to contract or shorten and thereby exert force. Alright. Elasticity is the tissue's ability to return to normal resting length when a stress that has been placed is removed. So basically, after you have performed some kind of function to be able to relax that muscle, when would that not be, or what would be an alteration of that? A real basic alteration. What's something that happens when that ability is not there? Contracture. Yeah, so if you've got a muscle contracture, that means that muscle has tightened, but it cannot relax. Okay. Next, we've got lactic acid. Lactic acid is a substance resulting from the process of supplying energy during anaerobic exercise, and it is a cause of muscle fatigue. Alright, next we've got atrophy. Atrophy is any weakening or degeneration, especially through lack of use through the muscle. Hypertrophy of a muscle is an abnormal enlargement, and it doesn't have to be a muscle, but abnormal enlargement of a body part or organ. Usually we're referring to muscle hypertrophy. And then joint, commonly you'll see arth. Okay, anytime you see arth, that's what that's meaning. It's dealing with joints. This is the space where two or more bones come together. Fracture, defined as interruption in the continuity of a bone. A sprain is excessive stretching of a ligament. And then strain is excessive stretching of a muscle or tendon. Okay. A little bit more of the review. Musculoskeletal system is the largest system, or the second largest system in the body, behind only what? Integumentary. Okay, so it's the second largest system. It includes the bones, the joints, the muscles, and all of the parts necessary to move them, including tendons, ligaments. Mobility is extremely important, and without mobility, what happens? What happens without mobility? Okay, atrophy. All right. What else? CVTs? Okay, yeah. All right. Anything else? Elasticity. Okay. Well, what about the skin? Skin breakdown. Okay, we can't move. We can't get a patient out of bed as easy, or the patient can't get up and move around as much. Skin breakdown. What else happens to the GI system? GI system slows down and you have constipation. Okay, these are all things that are a direct result of lack of mobility. Also, respiratory issues. What respiratory issues can occur? Pneumonia. Yeah. If we're not using the lungs to bring in more air and blow off more air, okay, if that respiratory effort doesn't happen, then our lungs get lazy and they don't get rid of stuff. Okay, we want these all of the lobes of the lung to be able to expand and fill with as much air as possible, at least at some point during the day. All right, we want to use those muscles, or not muscles, but also the lung tissue itself. All right, what happens when we get old? Everything goes downhill. Well, yeah, things start to change. All right. What about related to the musculoskeletal system? Sorry? Okay. Fractures. Yeah, you're more likely to have fractures. What else? All right. Osteoporosis. And we're going to talk about osteoporosis quite a bit. Yeah, and osteoporosis specifically dealing with the changes to that skeletal structure. Okay. And does anybody know what osteoporosis is? Okay. Brittling of the bones. Okay. Yeah. It's a breakdown. It's kind of a ramped up, severe version of osteopenia. Does anybody know what osteopenia is? Yeah. Well, we have a reduction in bone density. Okay. Reduction in bone density. Osteoporosis is when we have a severe deterioration there. We have severe loss of muscle, or I'm sorry, bone density. I missed something. Oh, all right, I got you. Also, we got postural changes, all right, and that kind of deals with osteoporosis. What kind of postural changes will you see? Kyphosis, all right, and what's kyphosis? Yeah, hunchback. Yeah, the head moves forward, the back kind of hunches a little bit, in I guess non-medical terms, but yeah, you have that hunching of the back. It's a structural change to that skeletal structure. Or skeletal system. I said structure a couple times there, didn't I? Either way, you've got skeletal structure changes. All right, what else? When that happens, what is the result when that happens? What's a physical measurement that we can take and see that? Height. As we age, you can lose 2 to 3 inches, okay, in your height. Related to that, for one, the hunching, you lose some there, but also as the bones kind of compact a little bit, you can lose 2 to 3 inches. Also, gait changes, okay, decreased range of motion, muscle atrophy, and then slowed movement is also there, okay. All right, so let's move into the bone classifications. Okay, kind of continue with our review here. Bones can be classified by several different ways. The first way is by their shape. Long bones, cylinder shaped, they're rounded at the edges, and these are the weight bearers. Okay, probably the best example of that's going to be your femur. Short bones are small and bear little or no weight. Well, at least not usually. When these bear weight, that's usually when a fracture is going to occur. A good example of this is going to be your phalanges. Okay, when they're bearing all of the weight, that's when you got, finger fractures and dislocations and that sort of thing. All right, flat bones. They protect vital organs and contain blood-forming cells. Does anybody know what a good example of this might be? Okay, scapula. Yeah, scapula is an excellent example. What else? Yeah. Now they tend to, they kind of fall in a different category. But yeah, that's definitely a flat bone. They kind of bear some weight, but they're not going to be in the long bone category. Okay. Skull. Yeah. Somewhat. And we'll kind of get into the skull in a minute. But yeah, you could. There are a bunch of different bones in the skull, so yeah, some of those are going to categorize there. Irregular bones. Okay, irregular bones are going to be unique shaped bones of the wrist and small bones of the inner ear. So that's kind of moving into that one a little bit. And also you got the sesamoid bones. These are developed within a tendon. The patella is a good example of this. Okay, this is the least common type that you'll see. All right, bones can also be classified by structure. Okay, and this depends on. This is kind of talking about density, and the area of the bone that it encompasses. The structure of the bone is going to be. You've got the cortex, which is the outer layer. This is dense, compact bone. Okay, the medulla is a spongy calcaneous tissue, and then also all bones are going to have both types, but the composition, so the percentage of each that the bone has, that's where you're really going to have change the classification a little bit. It just depends on how dense that bone is. The more dense the bone is, the stronger the bone is. Okay, the more resistant it is to fracture. All right, some of the skeletal system functions. Skeletal system provides a framework for the body. You got a couple for the body, and allows the body to be weight bearing or upright. It assists in movement throughout muscle attachment and joint formation, and it supports the surrounding tissues, protects vital organs, and manufactures blood cells in the red bone marrow. It also provides storage for mineral salts, such as calcium and phosphorus. Okay. The joints. A joint is a space where two or more bones come together. It provides movement and flexibility in the body. And there's different types, and this is important. You need to know these different types. Synarthroidal joints are completely immovable joints. Okay. The amphiarthroidal arthroidal are slightly movable. This is the pelvis. And then diarthroidal is what you'll commonly hear. A lot more things that can kind of go wrong with the diarthroidal or synovial joints. These are freely movable, such as the elbow and knee. These joints are the only joints that are aligned with synovium, which is a membrane that secretes synovial fluid for lubrication, and also it's there for shock absorption. It also has the bursae. Bursae is the little sacs of synovial fluid. It helps to promote smooth articulation of joint structures and allows for the tendons to slide easily with movements of bones. It's kind of like the oil in some mechanical device. You got to have that to lubricate and allow those bone structures to move freely. You don't want too much, and then we've got other problems. Specifically, you've got ball and socket joints. This is a type of synovial joint. It permits movement in any direction. This is the ball and socket joints found in the shoulder and hip. Hinge joints, they allow movement in one plane. Elbow flexion and extension. The knee can also rotate slightly, so it's going to be classified. You kind of think of the knee, but it's got a little bit more function than just a straight hinge joint. That's going to be the condylar. The condylar joint flexes and extends with slight rotation, so the knee kind of falls into that category. You've got biaxial joints, which deal with more of a gliding movement, so the wrist. And then finally, you've got pivot joints. Pivot joints permit rotation only. So this is going to be kind of your radio-ulnar area. Okay. All right, so that's the joint. Now we're going to talk about what holds it all together. Okay. So what is the purpose of connective tissue? Anybody got an idea? Other than what I just said? Okay, connects bone to the tendon, allow movements. Okay. Any others? All right, this is kind of the connective tissue. Is kind of the glue that holds the structures together. All right, kind of simply, but also they store fat, transport substances, provide protection, and also help to repair damaged tissue. Connective tissue disorders are often manifested as joint disorders, since the joint mobility is going to be the functional, or I guess the primary function. We've talked about this a little bit, but some of the age-related changes you'll see. As the bone ages, bone reabsorption accelerates, decreasing bone mass. This is known as osteopenia, and predisposes the patient to injury. Osteopenia can lead to postural and gait changes, increased risk of fracture, increased bone prominence. You'll also see cartilage degeneration, decreased range of motion, muscle atrophy, and bradykinesia, or slowed movement. All right. Some of these are expected. I mean, this is something we anticipate to see as the patient gets older. Postural and gait changes, absolutely. Okay. Even kyphotic or kyphosis posture, you will see that hunching of the back. However, 2 to 3 inch height loss is not normal. Okay. When it's moved into osteoporosis, that's when we've reached the severity level that we do not expect to see. Okay. This would warrant intervention treatments. What do you think if we have a patient with significant changes in terms of bone loss, what's our big nursing, I guess the nursing diagnosis there? Risk for falls, it's going to be a safety thing, okay? Risk for falls is a huge component as the patient gets older, okay? All right, we've also got increased bone prominence. What could this cause? Increased bone prominence. Skin breakdown, okay? So we've got the safety aspect, but we've also got risk for breakdown in skin integrity, altered skin integrity. All right. The patient population most at risk, as the I guess as at risk for these musculoskeletal age-related changes, is going to be older, thin, Caucasian women. They are at increased risk for developing severe osteopenia. All right, and then that's the categorization. The severe osteopenia is the categorization of the osteoporosis. All right, so we're going to assess a patient's musculoskeletal system. Okay, the patient comes in with, we've got some significant issues that we've noticed. We want to develop or obtain a history. What do we need to include in our patient history? Or what do we want to ask? Okay, history of falls, history of fractures. Absolutely. What else? Anything else you can think of? Diet? Absolutely. There's a huge nutritional component to the... Okay, absolutely. And it kind of ties into our nutrition, but yeah, you've got Crohn's disease, which is a huge risk factor because it changes our absorption, the ability to bring in and obtain those nutrients. Exercise, that's a big thing. We don't know how much, how often, what types of exercise. Why would the type of exercise be important? What now? That's it. You want to know the impact level, okay? The level of impact could lead to lots of skeletal issues, okay? Now, we do want some weight-bearing activity, right? Why would we want weight-bearing activity as much as possible? It builds bone structure. That's one of the driving factors that helps to build that bone structure. Now, we don't want it to be so high impact that they're at risk for the fractures, but that does help to grow the bone density. Okay, some other things, and it's important. It's not just what fractures have you had. You also want to know about some of the risk factors for future injury. Also, risk factors for conditions that maybe weren't diagnosed previously. A previous MVA. Okay, they've had a car wreck. I had this car wreck 2 years ago, and now my neck's hurting, my back's hurting. There was some issue that maybe was slight then, but it's grown into something that's a little bit more noticeable now. There's pain that's being experienced now that they didn't see previously. Alcohol and tobacco. We'll know about alcohol and tobacco use. Both of these will slow muscle growth. Okay, they have that component there that you need to be aware of. Also, occupation. Okay, what occupations would we want to really know about? I mean, really all of them, but what in particular would put a patient at more risk of musculoskeletal issues? Okay, the more they stand. Okay, sedentary. Whether they stand or sit. I mean, we want to know both, right? All right, what else? Okay, a lot of time typing. Any others? What about construction? They're at risk for a lot of, maybe they've even fallen and don't realize it. A lot of these structural or skeletal changes and even muscular changes can occur over repeated exercise or repeated activity. That's not necessarily hey, they fell down and they broke their leg and they got a bone sticking out of their leg. That's obvious. That's what we know immediately about. It's that repetitive exercise or repetitive activity that occurs, and you see the changes 10, 15, 20 years down the road. What are they at risk of in the future? That's a huge part of it that we kind of forget about a lot of times. All right. Some of the other issues. What about diabetes mellitus? Why would that be something important we would want to know about? Well, diabetes affects everything. If you hadn't figured that, I mean, it's a disorder and an issue that encompasses all of the systems of the body. Yeah, you can see significant changes. Specifically, well, not specifically, just one component of that. What are they at risk of? Neuropathy. Okay, so you've got nerve changes that can absolutely affect mobility. They can lead to atrophy of muscles. They can lead to contractures. But you've also got infection too, right? Osteomyelitis is a huge problem that they'll have. Osteomyelitis, you got that infection in the bone, and once it kind of gets into the bone, it's hard to get rid of a lot of times. Also, what about healing? A diabetes mellitus patient, they have trouble with healing. That's a huge component there as well. Once they have the fracture or they have the infection, the ability to heal, it's a lot harder to treat there. All right, and we talked about nutrition a while ago, specifically dairy intake. Okay, we want to know how much calcium are they bringing in. Are there some changes in the diet and the calcium intake that need to occur? What are the risk factors? We start looking at that as well. What changes we need to make there? We're going to look at lactose intolerance. Why do we want to know about lactose intolerance? Yeah, I mean, a patient that's lactose intolerant, they're really at risk because they're not able to take those foods in that are high in calcium. Okay. Obesity. We want to know about height and weight. We want to look at all that kind of stuff. Obesity can strain bones and joints, so we want to be aware of that. We want to kind of put that patient in kind of in that risk factor category that we monitor closely. All right, so now we'll talk a little bit about our assessment. Okay, so a patient comes in and we're inspecting or assessing the musculoskeletal system. All right, general inspection and posture. This can be assessed when the patient walks into the room. Okay. Or as you walk into the room, you want to look and see, okay, is the patient moving? If they've walked into the room, you can tell a whole lot about their gait, right? You can tell a lot about how they're able to move. Are they wincing in pain with every step? Range of motion exercises are a good way to kind of see that, but also not just you walk in and move their arm. We want to see how well they can do the active range of motion. Assess the strength. The hand grasp. The pedal push. How well can they move their leg up and down? If they can get up out of the bed, hey, we kind of like to see that. You don't have to walk in at clinical and tell the patient to get up and walk to the bathroom or anything. But that's kind of a continual assessment throughout the day. You want to see that. All right. So, with gait, we look at the balance, steadiness, ease of stride. Posture is a big part. We look at posture. A person's alignment when standing and walking. All right. When dealing with the face and neck, we want to look at assess for TMJ. And that, not just with that joint, but with all the joints. We want to hear the crepitations and the lack of a better term, just the popping. Okay, popping when they move. All right. They could have a lubrication issue. The joints just don't. Their bones are cracking together. Not able to move as easily. The spine, and look at common spinal deformities. what's one that you've probably all had the pleasure or about to have the pleasure of go assess for? Scoliosis. All right, scoliosis. The earlier they can diagnose that, the better. That's why you go out to the elementary or probably middle schools and look at that. The earlier you can diagnose, the better. Commonly, you'll start seeing that structural change at adolescence, puberty age children. Okay. The lordosis is when the neck goes back and the stomach goes out. Okay, yes, that's for that, but also the kyphosis, the hunchback we talked about. The hands have all kinds of joints in them. There's lots of bones and joints there. Kind of makes it difficult to assess sometimes to see where the problem actually is occurring. But that hand grasp, yeah, you're looking for muscular strength, but you also want to see, can all those joints, are all those joints functional? Do they work? Absolutely, and we'll talk about a little bit of that. When you're dealing with arthritis, you'll see a lot of those changes there, especially in the hands. That's a, you can kind of start, and I'm sure you've seen this. You walk into a grocery store, or you go to church or wherever, and you're kind of looking at people and trying to diagnose a little bit just from what you see. You can walk in and see, patient's got bilateral joint. Okay.
Don't fall over. I need this stuff. You brought it.
Here, it stood right here. About to knock over my puppet show.
Or it might be really high. Okay. Thank you. All
Okay.
right.
All right.
Okay. I think that's good.
All right, where was I? Oh, when you're out in public, you start to kind of look at some of these changes, and you can just kind of, from a physical assessment standpoint, you just walk in the room and you observe. I tell my students in clinical a lot of times, the assessment doesn't have to be a formal, I'm walking in and now I'm going to inspect your head. Now I'm going to look at your face. Now I'm going to look at your arms, your neck. A lot of these things you can walk into the room and start assessing immediately. And it doesn't have to be, can you move your neck? You talk to the patient and if they look over, they've got good range of motion in the neck. Muscle strength. You walk in, you can shake a patient's hand and see right away, some of that muscle strength. So it doesn't always have to be that formal assessment. All right. The joints, dealing with the hip joints. Okay, the hip joint's difficult to palpate. Okay, so I wouldn't recommend going and necessarily palpating that as much, but you can see the movement. You can see, ask the patient, do they hurt when they walk? Do they hurt when they move their leg up? If you're doing a musculoskeletal assessment, and you ask them to bend their knee up to their chest, move their knee up to the chest, some of them will say, I'm not doing that, that hurts. That's a pretty good assessment already. So, we're not going to go through all of this, but just in general terms, be thinking of ways that you can almost informally assess some of these things. Okay. One other thing I did want to touch, neurovascular assessment. Okay, what's involved in neurovascular assessment? Because that's very, very important when dealing with the musculoskeletal system. All right. The 6 P's. Y'all know the 6 P's? All right. Pulselessness, pain, pallor, paralysis, paresthesia. What's that last one? Poikilothermia. Okay. So y'all know all those, right? Those are very, very important when dealing with the musculoskeletal system. We want to know that the circulation is reaching even the tips of those fingers. Okay, you got a patient in a cast, you got a patient that's had a fracture. The fracture itself is a problem, but if you lose circulation to the end of that extremity, what could happen? Necrosis. We lose the extremity. So now, yeah, we got a problem with the fracture, but if we've lost the entire extremity or part of that extremity, that's a much greater problem than even the fracture. Okay, that's a huge part of orthopedics and musculoskeletal assessments. Okay, and then this final psychosocial assessment. Why is that important when dealing with the musculoskeletal system? I mean, you know, we're dealing with bones. Why don't we want to deal with the brain? Okay. Yeah. Okay. And okay. Let's say I walked in and told you this is the last day you're ever going to be able to walk. You think that's yeah, I mean that's definitely going to be a psychosocial issue, right? Not only does that completely change their life, their day-to-day, livelihood, how they make money, how they interact with kids, family members. So, some of these issues that we'll talk about and some of the injuries that you'll see later on, they're pretty traumatic in terms, not just physically, but also emotionally and mentally. And that's a component you can't forget about. Also, has anybody had a fracture? Anybody ever broken an arm or a leg or something? It hurts, right? It's not something that's just, I'll take some Tylenol and get over it. It hurts. There's pain involved with it. Pain is a huge component of orthopedics in the musculoskeletal system. You'll probably, if you take care of an orthopedic patient that's had significant surgery or some type of significant injury, you're going to give a whole lot of pain medicine. And it's warranted because it does hurt. There's a lot of pain involved. And sometimes the doctors kind of forget how much they are hurting that patient a little bit. So you have to be an advocate a little bit. Hey, look, before you go and set that, let me give some pain medicine. Before we manipulate that, that arm. Make sure that you're an advocate for your patient. All right, so here's some of the other assessment techniques, and you've seen these. We're not going to go into in depth on these, but you can look at this. This is some of the movements that you would want to assess. Yeah, we're going to move on, but be aware of this. Y'all had this in the first musculoskeletal unit you had, I guess, a couple semesters ago. Was it just A and P? What was you had it in fundamentals too? Okay. I thought you probably had some of this. Now, and a lot of what I'm covering today, I'm sure, but it's a good review, I hope. But be aware of this, okay? The different types of movement that you would assess. All right, so now we're going to start talking a little bit more in depth about how we assess for alterations. All right. Arthroscopy, well, what do we say arth was? That's a joint, okay? So what do you think this is going to be? Joint scope, okay? They take a camera in and assess the joint. Arthroscopy. It's the fiber optic tube inserted into the joint for direct visualization. Okay. The patient must be able to flex the knee, and exercises are going to be prescribed for range of motion. All right, we're going to evaluate neurovascular status of the affected limb frequently. Analgesics are going to be prescribed, and we want to monitor for complications. What complications do you think we would look for when they take a camera on a tube and stick it into somebody's joint? Swelling, okay? And swelling is going to be expected, but significant swelling, uncontrolled swelling, yeah, that's going to be an issue. All right, what else? Infection, there you go. Infection's a huge one. Bleeding, bleeding's another one. There's not usually a ton of blood involved with an arthroscopy, but if there is, then we know we got an issue, for sure. Any others? Those are the big ones. Infection. Anytime you introduce something new to the body, pain, we look for pain. Obviously, that's going to be expected, not necessarily a complication, but that's something we're going to address. Bleeding's a big one, too. All right. This is just a look at a procedure. This is an arthroscopy of a shoulder. And I'll tell you, when I was, I guess I was in high school, I volunteered to do, I think it was over at Crestwood. Volunteered, and I was working in the PACU. This is a volunteer. I did charts and stuff like that. Got them ready. But they let me go back and watch a surgery. And the arthroscopy, it was a shoulder arthroscopy that we were watching. So here I am. I'm a student. I'm 16, 17 years old. And, they get you in the scrub. You're decked out. Now, I'm not sterile. I'm not, I haven't been scrubbed in. But I'm kind of standing over in the corner watching. Pretty neat. And all of a sudden I hear the surgeon say, "This isn't working. We're going to have to open them up." So the arthroscopy didn't work, so they go in and they're going to do an incision. No, I'm sorry. I got that backwards. First, he looks at me, and I guess he thought I was the ortho tech or surgical tech or something like that. And he looks at me and says, "Go grab me blah, 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 blah." What? Okay. So I go over there, and he said, "It's right here in this drawer." So I go over to the drawer, and I grab it out, and I just reach over to hand it to him. And it was like the whole OR just stops. What's going on? Why are you trying to hand me something that's not sterile during this operating procedure? And so they all just kind of look at me, and they said, just open it up and drop it right here. Okay. All right, so we're good. So we've done that. And I knew they just really looked at me like, why is this guy doing this in the middle of an OR? Well, he looks over at me and he says, "Aren't you so-and-so from ortho tech, whatever?" I said, "No, I'm just a student. I'm just a volunteer." And he said, "Oh, okay." So he was fine with it at that point. It was like, man, what's this guy doing? Well, the tool that he wanted me to find that I didn't have, or I didn't know how to tell him how to use, because he thought I was ortho tech. That guy hadn't made it there yet. So he ended up having to open the patient up because that tool wasn't there or wasn't functioning. I know it doesn't have a whole lot to pertain here, but it was kind of an interesting thing. I mean, it was, even the ortho techs and I guess the surgical technicians, whoever it is that does that, pretty important too, to be able to make sure that those tools work. I guess that was my first experience in an OR. And I tell you, I think they about kicked me out right there until they found out who I was. But it should be a little less invasive. It should be a little easier on the patient. The arthroscopy is designed to not be quite as traumatic to the patient. Some of the nursing interventions that we do want to make sure of, okay? Because, we're not performing the arthroscopy, right? We don't need to know how to do it. We need to be familiar with what kind of goes on, but in terms of the procedure, that's not us, okay? This is what you need to know about an arthroscopy, the nursing interventions. The patient needs to be NPO for 8 to 12 hours prior to the procedure. Obtain informed consent. Anytime they introduce anything invasive, you got to get a consent, okay? Administer pain medication as prescribed post-procedure. Assess the neurovascular status of the affected extremity. An elastic compression bandage should be worn post-procedure for 2 to 4 days as prescribed. That's another key there, as prescribed. You may have one doctor that wants this kind of bandage. You may have one doctor that wants this kind of bandage. You follow the orders. All right. Instruct the client that walking without weight bearing usually is permitted after sensation returns, but to limit activity for 1 to 4 days, again, as prescribed, following the procedure. Instruct the client to elevate the extremity as often as possible for 2 days, following the procedure, and to place ice on the site to minimize swelling. A huge part of orthopedics and musculoskeletal nursing, I guess, is going to be limiting swelling. Anytime you've got an extremity that's had some type of trauma or surgery done to it, you want to elevate. minimize that swelling. Reinforce instructions regarding use of crutches, which may be used for 5 to 7 days post-procedure for walking. Obviously, that changes depending on the surgery, depending on how well the patient's doing. Then also advise the patient to notify the healthcare provider if fever or increased knee pain occurs, or if edema continues for more than 3 days post-op. Okay, that's your teaching there. All right. Now, some of the diagnostic tools that will be used when dealing with the musculoskeletal system. First, we got X-ray. You want to see the fracture. You want to see where the damage has occurred. You want to diagnose if the fracture has actually occurred. All right, tomography. We got CTs and MRIs. These are a ramp up from the old X-ray. CT scans, they create a 3D image from multiple X-rays. Okay, they kind of combine them all together and form an image. This has become one of the most commonly used diagnostic tools for musculoskeletal issues. They'll even use contrast, and it helps to enhance the images, allow for better visualization. All right, MRIs are a step up even from the CT. It's more accurate with better visualization of the joints, soft tissues, and tumors. Why wouldn't we just go straight to an MRI if it's better? Money. Yeah, it's a cost thing. Okay. Why wouldn't we go straight to a CT? Sometimes they will go to a CT, but when they can possibly diagnose it with an X-ray, that's a money thing again. I mean, be aware of that. Because it'd be a lot better if everybody just came in, we just knocked out a CT or an MRI or whatever, and we just move them on along, right? And it doesn't work that way. Bone scans. Bone scans can also be used. It's radioactive injections that allow for visualization of the bone density, tumors, arthritis, osteomyelitis, and osteoporosis. All right. Next, we've got myelography. This is contrast. It's used to evaluate the spinal cord and vertebral structures. And then finally, we've got arthrography. The use of contrast and X-ray to evaluate the joints. Okay, remember that arth there. Got to be dealing with the joints then. All right. Several of these we use contrast with. What do we want to check on before a patient goes down for any procedure with contrast? Allergic to what? All right. Shellfish, iodine allergies, all that good stuff. Okay. Or if they're just specifically allergic to the contrast itself. So, yeah, there you go. And they'll actually stop that. They'll stop the metformin post-procedure, or post whatever CT, MRI. They'll say, don't give that for however many days. Quite commonly. All right. Next, we've got lab tests. Lab tests include serum calcium. We'll see that 9 to 10.5. Serum phosphorus, 3 to 4.5. Alkaline phosphatase, 30 to 120. And then we also look at serum muscle enzymes. And I know you've talked about some of these in cardiac, right? I'm talking about creatinine kinase. All right. What's creatinine kinase? You didn't hit any of those? Well, creatinine kinase. Some of these are our cardiac enzymes we look at. All right, and it may be that this is kind of farther on down the line here with, second level. I don't know. I don't know when you take what now. But creatinine kinase, it's a skeletal muscle, and so what is the heart? It's also a skeletal muscle, right? Okay. But this will pick up when there's damage that has occurred, muscle injury, to any of the skeletal muscles. Okay? It increases 2 to 4 hours after the muscle injury, but it's not specific to cardiac. Okay, so it could be done if you have, I don't know, a muscle tear, maybe a, I don't know, whatever muscle. You have damage to that muscle, cardiac enzymes are going to go, not cardiac, but creatinine kinase will elevate in 2 to 4 hours after that injury. So that's why we would use it more in musculoskeletal. With the cardiac system, they're going to use that to help diagnose heart attack. Okay, patient comes in with chest pain, and their creatinine kinase, their creats are going up. You can kind of start deducing, hey, maybe there's some cardiac muscle damage there. All right, it's not as important as myoglobin. Y'all did touch myoglobin, right? Maybe. Myoglobin is a specific cardiac muscle. Okay, so that's one that you'll see. It's even more important. All right, moving on. This also, and it's another, and I should have mentioned this too, but this can also occur during heavy exercise. As a patient exercises, or a person exercises, some of this, creatinine kinase, you will see some of these elevations on a normal level. I mean, if you've got a patient that's really working out hard, there is going to be some muscle breakdown so that it can be built back up. And so that component to it you'll also see. So you have to kind of ask questions along with that, right? If you have a slight elevation, but the patient's just ran, 2 miles, or maybe they've done a heavy workout lift, or something, you may have these false elevations, or elevations that are not quite as telling. But anyway, all right. Aspartate aminotransferase, or AST. This elevates in patients with muscular dystrophy or skeletal muscle trauma. So this is just another indicator we look at. Also aldostase, aldolase, or ALD. Again, this is going to elevate when you have the muscular tissue trauma. And then finally we've got LDH, or lactic dehydrogenase. This is more of a skeletal muscle necrosis issue. Some type of muscular skeletal muscle has died. Also in muscular dystrophy, and then extensive cancers. Usually there's been some type of breakdown that's caused tissue death. All right. Next diagnostic tests include bone biopsy. This is not done quite as much, and also muscle biopsies. These biopsies are done. They help us to evaluate and diagnose infections, neoplasms, inflammation. They're not done near as much now. Used to, before they had CTs and MRIs, they would do these a little more often. They help to diagnose atrophy, inflammation, that good stuff. All right, some of the other more common diagnostic tests we'll also use with musculoskeletal issues. CBCs. Why do we want to look at CBCs? Okay, infection. All right, production of red blood cells. Definitely. What's inside of bone? It's blood. Why is bone there inside of, why is blood inside of the bone? That's where it's produced. Okay. We want to, if you have reductions in blood counts, it could be an issue of bone production. There may be a problem inside of the bone that's preventing it from producing at adequate levels. Okay. So that's a good indicator. A lot of the leukemias and things like that, you'll see some of these alterations. CBC will also use for bleeding. You've got a traumatic musculoskeletal injury. A lot of times there's a lot of blood involved. All right, the risk for hemorrhage and bleeding is just pretty high. Also, and we talked about an infection. ESR, or SED rate, erythrocyte sedimentation rate, SED rate. It increases, and as it increases, it's a good indicator of inflammation. So that's what we're looking for there, inflammation. C-reactive protein, or CRP, is also produced by the liver when there's inflammation present. So that's another big one with musculoskeletal system. Next, we got rheumatoid factor. All right, this is not a, yeah, if it's positive, you got rheumatoid arthritis, but it is a good indicator that there's some type of anti-inflammatory action going on. Okay, this measures the presence of immunoglobulins, IgG and IgM, that develop with connective tissue diseases. A positive titer, again, does not always indicate that the patient has rheumatoid arthritis. It can also be elevated with leukemia, liver disease, renal disease, but it does indicate that there's some type of inflammatory thing or process going on. You read my mind. All right. Got one more question. Somebody beat you to it over here. All right, so now we're going to start in with actual alterations. Okay, we've done a little bit of a review. I've gone over some of the diagnostic testing and tools that we'll use for diagnosis of the alterations. But now we're kind of getting into the alterations part of it. So we're going to start out with degenerative alterations. These are non-inflammatory. This is wear down of a joint or wear down of a bone, that type of thing. Okay, so we're going to start out with osteoporosis. Osteoporosis is a chronic metabolic disease in which bone loss causes decreased density and possible fracture. Okay. Patients are often unaware that they have the condition prior to suffering from a fracture. And skeletal structures most often affected include the spine, the hip, and the wrist. Osteoporosis is related to healthcare expenses, osteoporosis related healthcare expenses in the U.S. total more than $18 billion per year. So there's a lot of money involved with it. That just kind of tells you how common it is. It's very, very common. All right. Osteoporosis is a result of bone remodeling that occurs continuously as minerals, calcium and phosphorus, are moved into and out of the bone. Now, this is normal. A normal bone remodeling process occurs in everybody from birth till death. Okay. Bone reabsorption is the pulling of the calcium out of the bone for use. Okay, what are some things that we use calcium for? Why do we need that nutrient? Okay, it's big in muscle contraction. It's a big component in the muscle contraction process. Okay, when you're dealing with that's why calcium disturbances or changes in calcium can affect the heart. It can lead to dysrhythmias. It can lead to changes in contraction. It can change contraction in every muscle. That's what tetany is, right? What happens with tetany? Have spasm or locking up of the muscles, twitching. Yeah, that's because we don't have the calcium that's necessary for to make that muscle contract. Okay. So when we talk about bone reabsorption, that means we have, or the body has pulled calcium from the bone for use. Calcium also serves as a buffer in the GI system. Okay, it buffers against the because calcium is a base, so it buffers against the stomach acid. So if you have highly acidic foods, well, you need more calcium to kind of regulate that. So that's part of it as well. Osteoporosis is when this bone remodeling or bone reabsorption occurs at an abnormal rate. Okay, basically bone reabsorption is occurring at a greater frequency than bone growth or bone restoration. Okay, and there's an imbalance there. So osteoporosis is excessive bone reabsorption of calcium with disproportionate bone regeneration. This results in a loss in bone density. We pull out more calcium from the bone than we can put back in, and then that's when you've got the changes that occur. So what's the big problem here? If we change bone density, what happens? It's not as strong. You're more likely to have the fractures, the skeletal changes will occur, all that good stuff. Okay. Now, why does this happen? Well, we've got certain risk factors that make the patient more prone to having the bone density changes. First, we're looking at family history. Okay. Patient that has a family history of changes well, not just changes, but osteoporosis, it's a really good risk factor. Also, thin, small-framed, commonly women, but it can occur in men as well. Postmenopausal women. The reason for the postmenopausal part, estrogen is a huge, I guess, advocate for bone density growth. As estrogen levels drop, the body loses that kind of the defense mechanism against bone reabsorption. So estrogen does not create bone, but it helps to prevent bone loss. Okay. All right. We also look at race. White women or women of European descent or Asian race are more likely to have osteoporosis develop. All right. We also look at activity level. Okay. Sedentary lifestyle. Well, for one, what do we say activity does for bone growth? Well, it increases bone growth. You know, I'm not talking about high impact, but impact exercises, weight-bearing exercises help to promote bone growth. So if you have a sedentary lifestyle, or even maybe a sedentary job, a job where you're working in an office a lot of hours a day, you're not able to get up and move around like you would like to. That's going to be a risk factor. Cigarette smoking, another big risk factor. Excessive alcohol use, increasing age, and also insufficient calcium intake. Okay, the more calcium the patient takes in at an early age, okay, and that's the key. We want to start, small children, adolescents, young adults. Start them out on high calcium diets, especially if they're falling into this risk factor, any of these risk factor categories, because that improves. The studies have shown that improves improves the risk, or it decreases the risk of developing osteoporosis or calcium-related deficiencies later in life. Now, also men. All right, men after the age of 50, due to decreased testosterone levels, also are at risk. Okay. Testosterone also helps to increase, or probably not even increase, but prevent that bone reabsorption similar to estrogen would. Now, these are primary osteoporosis risk factors. There are some secondary risk factors, basically meaning they come from something else. I mean, it's coming from some other type of issue that leads to it. It can occur with use of corticosteroids. All right, corticosteroids. Also, increased use of aluminum-containing antacids, so Mylanta, Malox. Also, proton pump inhibitors. Prilosec, Nexium, Prevacid. Thyroid medications, thyroid-reducing medications. So patients that have hyperthyroidism, some of the medications that we'll give for that. And then also anticonvulsants. Now, that's not saying that anybody that takes these is going to develop osteoporosis. These are risk factors. This is something that you kind of add into the risk factor category. Patients more at risk because they've had prolonged corticosteroid use or Mylanta or whatever. These are just some of our risk factors. Some of the signs and symptoms. Pain that occurs with activity or lifting. Problems with balance. Decline in height form from vertical compression. Kyphosis of the dorsal spine, also known as Dowager's hump, hunchback, that kind of thing. So you got the hunched over kyphosis. Degeneration of the lower thorax and lumbar vertebrae on radiographic studies. Okay, these are things that we will see that kind of lead us to believe, or lead us to, or the provider to diagnose osteoporosis. This is just a look at some of the skeletal changes you'll see with a patient with osteoporosis. And you can see there, height from 5'6" to a little over 5 foot. That's the big one there. Yeah, that's really all you can see there. You can see where the ribs have basically moved down into lower onto the pelvic girdle. They're a lot closer there. But this is 40 to 60 and then the 70. Okay. So what do we do as nurses? This is the important thing, right? Safety to prevent falls and fractures. Patient that has osteoporosis, safety is going to be the priority. We want to maintain a safe environment by removing any object from pathways, and also encourage the use of handrails. Ensure proper use of assistive devices, including canes, walkers, any other assistive device. You want to move the patient gently. Okay, move gently. Use draw sheet when turning and repositioning. You want to assist with ambulation. These are going to be your patients that fall into the fall risk category. Okay. Encourage active range of motion exercises as much as possible. All right. What's the difference in active and passive? Yeah, they can do it themselves. We want them to do it. Okay. We want to encourage, as long as the patient can, and it's as long as it's safe, we want to encourage weight-bearing activity. That's extremely, extremely important. You need to know it. Okay, weight-bearing or low-impact weight-bearing exercises and active range of motion, as much as the patient can possibly do. This will improve joint mobility, increase muscle tone and strength, and promote bone formation. That's a huge part of it there. We want to promote as much bone growth and bone regeneration as we possibly can. All right, so these are your nursing interventions. The collaborative interventions is still important because we play a role in this, but these are not going to be your you're not going to prescribe these medications. You would give those if prescribed. So, administer medications as prescribed to help prevent further bone loss. First category, very, very common, biphosphonates. They inhibit bone reabsorption. So they inhibit the process of taking the bone or calcium out of bone. So, this is the important part of the nursing intervention here. Nurse should instruct patient to take with a full glass of water in the morning. Okay, that's another part that's not even up here. In the morning. Okay, early in the morning with a full glass of water at least 30 minutes before meals. And they also need to remain upright for 30 minutes after. So if it's a once-a-day medication, they need to take it 30 minutes before breakfast. Okay. Now, there are times when they may order it more often, but they need to make sure they take at least one of those doses early in the morning before breakfast. Okay. I've said it 3 or 4 times. And we'll take note of that. All right. Some of these medications include Fosamax, Boniva, and Benefos. All right, next category, selective estrogen modulator. We've said postmenopausal women, as estrogen levels drop, are more at risk, right? Well, these are estrogen modulators. They mimic the effect of estrogen to reduce bone reabsorption. They don't cause bone creation or bone growth, but they reduce the bone reabsorption of calcium. And I've said it a couple times, but make sure you understand bone reabsorption means we're taking calcium out of the bone. That doesn't mean the bone is absorbing the calcium. That's taking bone away, or calcium away from the bone, reabsorption. Because that's where we store it, right? We have extra calcium levels. Well, the body stores them in the bone. So that's good. That's why we encourage as much calcium as we can get in. Get as much calcium in, and the body, if it's working normally, we'll store that in the bone, making it the bone stronger. All right, and then so some of these selective estrogen modulators, Avista or raloxifene, and Forteo or teriparatide. DEXA scans may also be ordered to measure bone density and evaluate for osteopenia. All right. Now we're going to talk about arthritis. And if you remember back, I said we're going to talk about the non-inflammatory, right? Well, we're going to do just a little bit of the overall arthritis, and then we're going to hit osteoarthritis, which is non-inflammatory. All right. But arthritis itself is divided, well, it's inflammation of the one or more joints. Remember, arth is a joint. Itis is inflammation, so arthritis is going to be inflammation of the joint. There are 2 main clinical categories for arthritis. Non-inflammatory, which is osteoarthritis. It's localized and non-systemic. If you do a lot to, I was a catcher and played baseball. I was a catcher, so my knees are shot. I had a lot of work on my knees, going up and down during baseball, and so my knees have a lot of I don't know if it's osteoarthritis, but I expect that coming down the line. I'm going to have that. It's localized. Okay. If you do something with one arm, okay, you're more likely to have problems locally in that one arm. It's not a systemic issue. Okay, that's an important distinguishing characteristic between osteo and rheumatoid arthritis. So non-inflammatory osteoarthritis is localized and non-systemic. This is more of a mechanical issue, osteo is. You know, you've worked that joint or that the bones there to the point where you're having problems in that one specific or multiple specific joints. Okay. Second type, inflammatory or rheumatoid arthritis, is systemic, and it is an autoimmune disorder. Well, not only rheumatoid, but that's the main one we'll look at, rheumatoid arthritis. You've also got systemic lupus erythematosus. There are over 100 different types of arthritis conditions that fall into one of the categories, affecting more than 46 million people in the U.S. But the big thing you need to know, non-inflammatory versus inflammatory, osteo versus rheumatoid. Okay. Some of these others, we've got synovitis, attachment arthritis, crystal arthritis, joint infections, cartilage degeneration, all this. Just know inflammatory versus non-inflammatory. Okay. osteoarthritis. Remember, it's non-inflammatory, it's local. It's the most common form of non-inflammatory arthritis, and it's also sometimes called degenerative joint disease. Okay. Basically, with osteoarthritis, the articular cartilage breaks down, so you lose that shock-absorbing cartilage. Kind of like you lose the pad. You lose the pad that helps to keep the joints. Well, it's between the joint or between the two bones where they come together. You lose that shock absorption. You lose the ability of that joint to move smoothly. New abnormal bone growth will occur. Bone spurs, what you'll commonly hear them referred to, where the bone grows, and this is a good example here. The bone growth occurs here, but it also is degeneration of the good bone, and that it regrows bone that's not near as effective, it's not as smooth, it doesn't fit as well, basically. The incidence increases with age. The person's over 50, and usually affects joints that are under pressure. The knees and the hips are probably the most common. Risk factors include obesity, and those with poor posture. All right, you can have, there's different classifications of osteoarthritis. Primary, they really don't know the main reason or why it occurs, but it's from some unknown factor that triggers the release of chemicals that break down joint cartilage. Aging and genetics play a significant role. The reason they say they don't know, I mean, they know there's some type, the mechanical process occurs. The reason they say they don't really know is because you can have one person that does the exact same thing. They can have the same job, the same activity level, and then you take another person with those exact same characteristics. One has osteoarthritis and one doesn't. You know, yeah, we know what functions caused it, but we don't necessarily know why one got it and one didn't. Does that make sense? Secondary is going to be associated with trauma, infection, congenital deformities, or corticosteroid therapy. It's the result of something else. We know something else caused it. All right, signs and symptoms. Okay. Some of the signs and symptoms of osteoarthritis. I'm going to give them to you and you got to write them down. All right. First one, pain. Okay. And this pain is going to change. Early in the progression of the disease, the joint pain and stiffness diminishes with rest and activity, or after activity and with rest. All right. As as osteoarthritis progresses, the late signs, pain is going to occur even with slight motion and at rest. All right, next, we've got sensitivity to changes in temperature and humidity. Sensitivity to temperature changes and also changes in humidity. All right, the third one, joint enlargement and crepitations. All right, is it going to be systemic joint enlargement or local? With osteo, local. So if I have a problem with my knee, I'm going to have enlargement of the joint in my knee, not necessarily everywhere else. Okay, and you can develop osteoarthritis in different joints, but it's not like it's a bilateral thing every time. There's going to be different degrees of damage. There's going to be different degrees of problems. Okay. All right, next. You've got nodules, okay, or nodes. Specifically, the Barrett's nodes, okay, see them there, and also Bouchard's nodes. Okay, so Bouchard's. So you'll see those nodules. Patient will have limited range of motion. Also difficulty with movements as they get up after prolonged sitting. Okay, so they're going to have trouble. If they've been sitting for a long time, they're going to have trouble getting up. They're going to have trouble getting out of bed. All right. Visually, you will see skeletal atrophy, skeletal muscle atrophy. A later sign is also difficulty with activities of daily living. All right, next, you've got compression of the spine. Be seen with radiating pain, stiffness, and muscle spasms. All right, so those are the signs. Okay, those are the things you'll see with osteoarthritis. Made you right so you can wake up a little bit, maybe. All right. The nodules, limited range of motion. Bouchard's. Alright, so those are the signs and symptoms that you'll see. The big thing is you're going to have the joint pain, not always bilateral. Usually it's unilateral joint pain in one or more extremities or one or more joints. But it's not a bilateral thing. You're not going to have the same signs bilaterally. Now, medical diagnosis, it's based on the health history and also radiologic studies. And a big one, 68% of females over the age of 65 will have some type of osteoarthritis. 68% of females over 65. The male rates are slightly decreased. I don't have a number for you, but they're just a little bit lower. And arthroscopy and MRI is going to be the big tools that we use for diagnosis. Arthroscopy and MRI. Okay, medically, the medical interventions. There's no known cure. Okay, it's not like we're just going to give them a medicine and the bone regrows perfectly and osteoarthritis never happened. That's not something we can do. So the goals are going to be decrease pain to a manageable level and maintain as much mobility as possible. Sometimes it's hard to improve that mobility a whole lot. Some of the exercises and things we can kind of improve on. But the main thing is maintain, prevent further loss of mobility as much as we can. Some of the improvements are going to occur because we cover up some of the pain. We cover up some of the those issues that prevent them from wanting to do that activity or exercise. So the drug therapy is going to center on Tylenol, NSAIDs, other analgesics, that sort of thing. It's pain related. Okay, manage that pain. Remember, this is not inflammatory, so we can't just give them an anti-inflammatory and that's going to take out inflammation. That's not what the problem is. All right, and then surgery is going to be the other. Okay, so these are the patients that will go in for a hip replacement, a knee replacement. This is going to be kind of the last resort, though. They want to try all these other methods, see if they can get them to a manageable level with the exercise and the, the medications. Surgery is kind of the last resort. Now, with this patient, the activities are going to change a little bit. You don't necessarily want the high, well, you definitely don't want high impact. With this patient, water aerobics, some of those yoga, stuff like that that's low impact is going to be usually the most beneficial. And we'll get to that in a minute. But this is severe osteoarthritis, and what's the key observation here in that picture? Okay, the nodules. All right. What else do you see when you compare the two hands? Okay, one's worse than the other. That's the key there. Yeah, she's probably got osteoarthritis in both hands, but it's not bilateral progression. Okay, one is worse than the other. That's a key distinguishing characteristic. I can't stress that enough. When we get to rheumatoid arthritis, these hands are going to look exactly the same. They're going to have the same progression, the same issues. All right, the big ones here, nursing interventions. I'm not making you write the nursing interventions, am I? Okay, good. All right, nursing interventions. Encourage weight loss if necessary. Avoid or limit activities that promote stress on the joint as much as possible. Okay. So this patient doesn't need to go try to run a mile. This is a patient you might recommend, again, the water aerobics or the yoga, or even walking. Okay. Remind the client that excessive use of the involved joint aggravates pain and may accelerate joint degeneration. Teach the patient to use correct posture and body mechanics. Ensure that patients with reduced or no mobility are positioned and turned as appropriate. That's important. Apply cold applications as prescribed to help with the pain, and encourage adequate rest, appropriate exercise, and activity. Plan rest and activity periods throughout the day to prevent overexertion and reduce the pain. And also teach the importance of maintaining a safe environment. All right, some of the surgical interventions, again, these are going to be last resorts. Okay, the joint replacement we talked about. Also, osteotomies may be done. This is when the bone is going to be cut to correct the joint deformity and promote realignment. Okay, they don't like to do osteotomies unless it's, it's basically they're cutting that bone to improve that alignment. One of the big contraindications on the joint replacement is the presence of infection, advanced osteoporosis, and also severe inflammation, which that shouldn't be the issue with osteoarthritis, the inflammation aspect. But that would be an indicator. If you've got severe inflammation, they're probably not going to do that joint replacement. But don't get that bogged down with the osteoarthritis. That's not an inflammatory. Inflammation is not going to be a characteristic of osteoarthritis. So perform when pain relief failed. Infection, advanced osteoporosis, and severe inflammation. Those are contraindications to joint replacement. All right, now we're going to talk real quick about inflammatory, probably not real quick, but we're going to talk about inflammatory alterations. Okay, we're going to talk about the second category of arthritis, rheumatoid arthritis, and then we'll talk about osteomyelitis. All right, rheumatoid arthritis is a chronic, progressive, systemic inflammatory autoimmune disease. So, chronic, progressive, systemic inflammatory autoimmune disease that primarily affects synovial joints. Okay. Rheumatoid factors, or RF, or autoantibodies that are formed and attack healthy cells. Healthy, not health, healthy cells, especially the synovium, and this causes inflammation. Joints are affected throughout the body bilaterally. So with rheumatoid arthritis, if you have pain and inflammation in one knee, you're going to have pain and inflammation in the other knee. Okay? Most commonly, you're going to see it in multiple joints. 1.3 million European Americans have rheumatoid arthritis, more than any other population group. The actual cause is unknown, but there is a strong genetic correlation. The disease can go into remission, particularly if diagnosed and treated early. But it decreases the amount of bone, treatment is going to decrease the amount of bone and joint destruction and help to reduce that disability, or the degree of disability. All right. No. Early treatment reduces the bone destruction and disability, level of disability. It decreases the amount of bone and joint destruction and reduces the amount of disability. All right. So I made you write down osteoarthritis. I'm going to make you write down the signs and symptoms of rheumatoid arthritis too. I know, I'm just being mean here. Pretty important though. All right. First, symmetrical bilateral joint inflammation. Okay, so what happens with inflammation? What's the, I'm saying inflammation, but what does that mean? Swelling. Yeah, that's the big one. Swelling, you may have the warmth, the redness, all that good stuff, but swelling is going to be the big thing there. So symmetrical bilateral joint inflammation. Fatigue. Generalized weakness. Weight loss. Anorexia. Morning stiffness. And joint deformity. All right, this slide is going to show you give you a good idea of the progression. Okay, early stage, moderate stage, advanced stage. Okay, this is what you'll see, and again, this is bilateral progression. Here's just some more of the changes you'll see. This is just general muscle atrophy, boutonniere deformity, and then swan neck deformity. Rheumatoid arthritis is a rough disease, especially when it's, obviously it's bad any time, but especially when the diagnosis is early. When you start having the symptoms early, that means there's a long time for that disease to progress and continue to get worse. All right, so our nursing interventions with rheumatoid arthritis. Again, maintain a safe environment. Encourage weight loss if necessary. Avoid and limit activities that promote stress on the joints as much as possible. Teach the patient to use correct posture and body mechanics. I don't know if you're seeing a trend here. Very similar to osteo, as far as our treatment. Ensure that patients with reduced or no mobility are positioned and turned as appropriate. Provide range of motion exercises as indicated by ordered activity level. And here's kind of a difference. Use moist heat. Compresses, whirlpool baths, hot showers early in the morning and before activity. This helps to reduce joint inflammation. Okay? So moist heat. That's another big one you need to remember. Use moist heat in the morning and before activity to reduce joint inflammation. Encourage adequate rest. Encourage appropriate exercise and activity. Planning periods of rest and activity throughout the day to prevent overexertion and reduce pain. And then also teach the use of assistive devices to promote independence and prevent complication. Also, education is a big part of this. Okay, you want to educate the patient. Take these medicines on a daily basis. Don't skip days. You know, take them at the same time each day. You know, encourage the weight loss, all that kind of stuff. Teach them the activities that they can do to prevent, you know, further damage. You also want to encourage as much independence as you possibly can. Okay, you know, this is a progressive disease, so their independence level is going to change as the disease progresses. But you want to maintain as much independence as you possibly can for as long as possible. All right, some of the collaborative management. You know, these are, again, you need to know these or be familiar with these, but this is not going to be the focus of what you decide to do for this patient. Okay. Some of the things they'll order, labs, including a SED rate. So what do we say a SED rate is going to evaluate? Inflammation. SED rate is going to evaluate or detect the presence of inflammation. And that SED rate may be important in diagnosing osteo versus rheumatoid. Okay, the SED rate's not going to go up on osteo. It is going to go up on rheumatoid. Also, you're looking at rheumatoid factor. Okay, so rheumatoid factor. Now, a positive RF factor is not always going to indicate rheumatoid arthritis. It's just one of those signs that could be. It is usually going to go up when the patient has rheumatoid arthritis, but it's not always rheumatoid arthritis if it does go up. Some of the other labs, presence of ANA or anti-nuclear antibody. Again, it's just a sign of the inflammatory response, that immune response. If they do an arthroscopic examination of the joint, they could see joint space narrowing. Again, you don't have to, you know, you're not going to go in and do an arthroscopy on the patient, but that's another sign that they'll use for diagnosis. Also, and this is one of these physical signs that you will see if it's getting bad enough, abnormal synovial fluid buildup. This is one of those big things that causes a lot of the pain and inflammation, the swelling. If you've ever heard of a patient having to go in and have their knee drained, or if you've had your knee drained or a joint drained or whatever, they actually go in and pull that excess synovial fluid off of the joint. Next, you've got a CRP level is going to go up, or C-reactive protein. Again, that's just another sign we talked about of inflammation. All right, so those are our diagnostic tools that are used to diagnose rheumatoid arthritis. Now, the medical treatments. We talked about the nursing interventions. Okay, medical treatments you need to be aware of, so you know how to kind of do it if they order it, but that's not your call. The medical treatment, there's no known cure. The goals are going to be to decrease pain to a manageable level and maintain as much mobility as possible. All right. Again, they may do a synovectomy. That's what we talked about before, where they go in and pull off the inflamed synovium. And then the surgery, they may do the total joint replacement, all that good stuff. But you know, it's not as common with rheumatoid arthritis because of that inflammation, because of the presence of the inflammation there, which is a contraindication, right? PT/OT, you need to collaborate with PT/OT. That's a big part of the nursing aspect. You know, when you're planning out the periods of rest and activity, you know, make sure that you consider the PT/OT schedule. Make sure that you consider, you know, the cooperation with PT and OT to improve that mobility. Okay, you know, you wouldn't want to take schedule a patient, or well, trying to think of a good example. You don't want to take patient down for PT and OT right before meals, or right before something that would affect their ability to perform activities of daily living. You know, you want to make sure that PT and OT has its time as well, because that's an important part of keeping the patient from losing some of that function. I didn't say that right, but you get the idea. You need to coordinate and plan out the patient's day, keeping PT and OT in mind. I guess is what I'm trying to say. Some of the medications that they'll use for rheumatoid arthritis. Tylenol. Okay, Tylenol's a big one. They'll use Tylenol a lot with RA. The big thing, what's the big deal with Tylenol? What's the nurse's responsibility on Tylenol? Make sure of what? Make sure they don't take too much. Okay. Adults don't need to take more than 4,000 milligrams a day. And there's a big push there with Joint Commission and all that, making sure we're not, you know, making sure we're not giving too much of the Tylenol. That's why they've taken it out of most of these pain medicines that they had it in combination with. You know, the Lortabs. They've reduced the amount of Tylenol that they give with the hydrocodone. There were a lot of patients that were being overdosed with Tylenol. All right, make sure that you educate your patients on that as well. Don't take too much Tylenol, or your liver's going to die. You know, you're going to kill off your liver. And then you got all kinds of other problems with it. So just add that in your education. NSAIDs, they will do NSAIDs as well. You want to monitor for bleeding, GI upset, renal failure, all that good stuff. But that is, you know, that's a good anti-inflammatory that they'll use. We've also got, and I guess we just need to go into some of this. The first generation NSAIDs. We've got this slide, we might as well use it, right? First generation NSAIDs, the non-steroidal anti-inflammatory drugs, analgesics, antipyretics, and anti-inflammatory medications. You don't necessarily need to know all the pathology, but it inhibits prostaglandin synthesis, and this decreases pain and deformity, inhibits platelet aggregation and clumping. Okay. Some of the examples, we've got the Motrin, Relafin, naproxen, aspirin. Aspirin's a little kind of moves in and out, but you know, it's sometimes categorized there and sometimes not. But monitor for the side effects. Okay, the GI upset, GI bleeding, bleeding due to the anticoagulation, drowsiness, increased blood pressure, all that good stuff. That's not necessarily what you got to remember. You do need to know those side effects. Monitor for bleeding is a big one. Okay. Some of the other interventions that you really need to know, though. Okay. Patients on first generation NSAIDs, teach them to take it with food. Okay. Or to take the enteric-coated forms of the NSAIDs. Patients need to report ringing of the ears, and also they need to assess for any bleeding, any bruising. Teach them not to take the NSAIDs if they're drowsy. And also beware of alcohol consumption in conjunction with NSAIDs. They're at risk for the GI bleed. All right, now, commonly, as the disease progresses, or if the NSAID, first generation don't work, they do have the second generation NSAIDs, and they've kind of garnered a lot of attention lately, but these are, well, they inhibit prostaglandin synthesis selectively. Okay, they selectively block the COX-2 enzymes, not the COX-1 enzyme. Basically, all this does, and all that being said, it blocks enzymes that are blocking this enzyme, impedes the production of prostaglandins by the COX-2 enzyme that often cause pain and swelling due to inflammation and other painful conditions. Okay? All that. They're just more selective. There you go. More selective. Some of the examples: Celebrex, Arcoxia. The key here, we want to warn about the risk of heart attack with these medications. Some of the more common side effects, though, are going to be the GI bleed, fatigue. Now, the GI bleed is there's less of a risk than with the COX-1, but the indication still is there. But fatigue, dependent edema, nausea, and also increased blood pressure due to fluid retention and dizziness. Now, just like with the first generation, they need to administer with a full glass of water, remain in the upright position 15 to 30 minutes after administration. And also, do not use with aspirin, alcohol, and then be careful with acetaminophen administration as well. They just don't need to take it at the same time. All right. Next type you'll see glucocorticoids. Okay, used in inflammatory and allergic conditions. They suppress normal immune response and inflammation. So you'll see hydrocortisone, Cortef, Solu-Cortef, Deltazone, Delta-Cortef, the corticosteroids. Okay, commonly they will inject corticosteroids into the joint, direct action. It helps. You'll commonly hear that. Depending on where the joint is, especially knees, they'll do that a lot of times with cortisone shots and things like that into the joint. But you want to monitor for muscular weakness, nausea, anorexia, hypotension, sodium retention, hyperglycemia, and increased susceptibility to infections. We're taking away the inflammatory response, so we are more at risk for infections. Yeah. All right. Muscular weakness, nausea, anorexia, hypotension, sodium retention, hypokalemia, hyperglycemia, and increased susceptibility to infection. And there's much more, but you get the idea. All right. The nursing interventions that are the key nursing interventions give the highest dose early in the morning, but again, that's not necessarily your call either, right? You give it as ordered, but they will order the highest dose early in the morning, lowest dose later in the day. The key here, stress the need to maintain the schedule as prescribed. Okay, if a patient's been on glucocorticoids for a long period of time, they can't come off of it right away. They can't just, one day take it and the next day decide, we're not going to take it anymore. It's very, very important that you educate the patients on that. You can really throw off the adrenal system. They also can cause or mask infection. Okay. Next, we've got disease-modifying anti-rheumatic drugs, also known as the DMARDs, DMARDs. They're used to treat rheumatoid arthritis. The action, the basis of the effects are unknown, but they're used to suppress antigens that trigger hypersensitivity reactions. Kind of fall into two different categories. Some are antimicrobial, some are anti-inflammatory. Some of the main ones you'll see: methotrexate or Folex, Plaquenil, Plaquenil, and azulfonide, AZULFIDINE. I guess it's sulfidine. All right. Common side effects here: anorexia, nausea, vomiting, diarrhea, and headache. All right. These have multiple. That's what I was about to get to. Yep. And there's a lot of different types of medications that fall into this category. So there's a lot of different things that you have to monitor for, but liver damage is going to be a huge component of that. Okay. Monitor for liver and kidney function. Monitor for GI disturbances. Avoid alcohol use. And then you'll monitor for toxicity by lab values. Also, and I don't even think I mentioned this one, but Arava, ARAVA, is a type that falls, or a medication that falls in this category. It should not be used by women that are of childbearing age. That's Arava, ARAVA. All right, some of the other anti-arthritic biologic response modifiers. These are just newer DMARDs. Okay, this is just a newer classification of the old disease-modifying anti-rheumatic drugs. These are used to treat severe rheumatoid arthritis in individuals that do not respond to the first line DMARDs. Some of the examples you've probably heard of: Remicade and Enbrel, ENBREL. These bind tumor necrosis factor, which is involved in immunity and inflammation. They just bind to it, prevent it from being able to further cause the inflammation. Common side effects. These are injected. They can be injected sub-Q in the arm, abdomen, or thigh. So you want to monitor the injection sites. Also monitor for abdominal pain, headache, dizziness, and upper respiratory infections. You get it. Abdominal pain, headache, dizziness, and upper respiratory infections. And then also heartburn.